Hey, I'm Dr. Scott Worden, the TOS guy. Welcome. Glad you're here to join us on this beautiful Tuesday here in California. We have beautiful weather and it's a beautiful day to discuss TOS. We're going to be doing a presentation called The Anterior Scalene Muscle is the Key to TOS. And already we have some comments coming in, TOS Unbound. We'll definitely address those and get to them at the end of the presentation, so stick around. All right, the anterior scalene muscle is the key to TOS. Remember, TOS is multifactorial. There's not just one thing going on, but we believe that the anterior scalene muscle is a big key, especially for people who are learning about TOS because they or a friend or a family member have it. So this is a start to understanding a whole bunch of things that are related to the anterior scalene. Let's have a look. Here's our outline. What is the anterior scalene muscle? Where is it? What does it look like? What does the anterior scalene muscle do? How do we image the anterior scalene muscle? And finally, why, after all this, is the anterior scalene muscle the key to TOS? What is the anterior scalene muscle? Let's take a look at some layers of muscles through the neck. Now, bear with me, these slides get a little busy. Some of them are downloaded from the internet. They have many labels, as you see here, but we're just going to start from the superficial layer of the neck, and we're going to head deeper and deeper so you have a general lay of the land. On the left side of the image, you'll see an arrow in a box that says platysma. Platysma is a very thin sheet of muscle just under the skin. It has no significance for TOS patients, except when surgeons go in, they make a flap, they dissect this muscle away. But as you take this muscle away, what you're going to see is some of the muscles on the right side. So we get a little bit deeper, and one of the biggest muscles we see in the front is called the Sternocleidomastoid Muscle. 3 words, Sternocleidomastoid. It attaches from the base of the skull to the anterior part of the collarbone and the breastbone here. So what it controls is flexing of the neck forward and turning of the head to the side. You'll see beneath the sternocleidomastoid muscle, there are a bunch of longitudinal muscles that run up and down in front of the larynx and the thyroid gland. These are called the strap muscles. Here's a deeper dissection. On the left side of the image, you can see some of the strap muscles. I've labeled them here. They have a bunch of fancy names. It's not really important, but they sort of stretch from the roof of the mouth down from the hyoid bone, which you do see labeled, and down to the upper part of the sternum and the collarbone. And these are muscles that help control the position of the larynx and the esophagus and the hyoid bone. If we go deeper than these muscles, we're going to get to the vertebral bodies, the bony part of the spine itself. And what you'll see is several muscles called longus colli, among others. There are several groups of muscles here. And you'll see that they attach to the anterior or front part of each of these vertebral bodies. And you'll see some of the scalene muscles for the first time. And the scalene muscles attach from the vertebral bodies down to the first or second rib. So these muscles now, as you can tell, are very deep in the neck. And what they do in many ways is they stabilize the neck. They help move it, flex it forward, extend it backwards. They also help it turn side to side. And you might imagine in a bike accident or a car accident where you might have a sudden twisting or a sudden flexion or movement of the head and neck, that these muscles would be some of the primary stabilizers, which also means if there's enough force, you could get micro tears in these muscles. All right, so let's boil it down again. Let's start with the cervical spine. This is an oblique view of the cervical spine, and this shows how the anterior scalene muscle, our key muscle here, arises from some of the lateral parts of these vertebral bodies, actually C3 through C6 in general, but it arises and forms one muscle that comes down and inserts on the first rib. Here's a simple diagram, again showing C3 through C6. The transverse processes are these little side bony wings of each vertebral body. And by moving it laterally, the scalene muscle has an effect on twisting, turning, even lateral bending of the spine. Again, you'll see the anterior scalene inserts on the first rib. There's a slightly different picture that shows the anterior scalene muscles on each side. And then here's a different oblique view to the other side, and it shows the anterior scalene arising from several vertebral bodies, coming down to insert on the first rib. Just for kicks, I've shown you a middle scalene muscle. The space between those two is called the scalene triangle, which you see here. Now, we all know that the nerves, the brachial plexus, have to pass around the anterior scalene muscle. The arteries have to pass through the same area. And the veins have to pass through a very similar area, but not exactly the same. We're going to show that. So this is a frontal view. We're going to see the anterior scalene quite well and the middle scalene behind it. And what we'll see here is the anterior scalene arises from several vertebral bodies and it inserts on the first rib. If you look at the anterior scalene muscle, you can look in front of it to see the subclavian vein. And you can see behind it is the subclavian artery in red and the brachial plexus. This again is the scalene triangle. Again, I'm going to emphasize the vein does not go through the scalene triangle, but the artery and the brachial plexus do go through the scalene triangle. And here we're just showing those important structures: the brachial plexus, the subclavian artery, the subclavian vein. Now here's a lateral view. Again, we're going to show those three structures: the brachial plexus and the subclavian artery, which pass through the scalene triangle, and the subclavian vein, which passes in front of the anterior scalene muscle. So what does the anterior scalene muscle do? Well, it may have numerous functions, and there is not total agreement in the literature on what the anterior scalene muscle does. I recently read a paper on studying this muscle in macaque monkeys, and so clearly people are still studying it to understand fully its function. You can imagine from this picture, if both anterior scalene muscles contracted at the same time, you would bend your neck forward. And I think that's just pretty obvious and simple. Well, what happens if you contract only one of these anterior scalene muscles? In this case, you're going to see the anterior scalene pointed out. The answer is that you do bend the neck forward, but you also bend the neck to the side of that anterior scalene muscle, and you also turn the neck in that direction towards the anterior scalene muscle you're studying. So again, we'll go back. We'll take a look. This is what the muscles would do if they both contracted. You would just bend the neck forward. But it becomes more complex when you use one muscle only, or if you use one more than the other. Again, it will bend the neck forward somewhat. It'll bend the neck to the side, and it'll twist the neck. You see the jaw in this case. The person's face is turning towards the side of the muscle that's activated. Now, the anterior scalene muscle is also called an accessory muscle of respiration. If you watch somebody with bad emphysema or another person who's having trouble breathing, you'll see the muscles of the neck working hard. That includes the sternocleidomastoid muscle we mentioned earlier and the anterior scalene muscles. In these cases, where the patient is struggling to breathe, those accessory muscles of respiration do something they're not primarily intended to do. They're accessory to the other breathing muscles. But when they do get activated, they can help raise the rib cage and improve the volume of air that you take into the chest. Now, in some people, they believe that this is why you relax the anterior scalene muscles first, or conversely, as Steve Talakowski, our friendly PT, has talked about, why you train the breathing in a patient so they get control over their anterior scalene muscles. Now, how do we image these muscles? Well, I'm not going to even show you x-rays because the muscles are essentially invisible on an x-ray. Let's take a look at 3 ultrasound images. These will all be on the patient's left side. Just happens to be the way we're looking at them. This muscle, the anterior scalene, is rather large. I'm sorry, this is actually on the right side, forgive me. The large anterior scalene muscle, you can see that the brachial plexus is numbered here. There's a needle, a long, thin white line. Somebody is doing a brachial plexus block or an interscalene block where they inject some numbing medication. And far off to the left side of the image, you see MSM, that's the medial scalene muscle or the middle scalene muscle. This is another ultrasound image we'll show. Again, we see the anterior scalene muscle. We see a few black dots that are parts of the brachial plexus, and we see the middle scalene muscle off to the left. One more ultrasound image. We see the anterior scalene muscle. We see the dots of the brachial plexus behind it, and we see the middle scalene muscle off to the left. Now, I've done ultrasound a lot in the past, and I think it's a great tool for live examination, but these are exceptionally good images. It's hard to get images this good. And often there's complexity where the anterior and middle scalene muscle are not so cleanly separated. And perhaps as you look at this, you see that the plexus and the muscles are all a similar shade of gray, which makes it very hard to separate them out. So let's take a look at a different modality, CAT scan. All right. On the patient's left side now, you see the anterior scalene muscle and the brachial plexus. This is a great image. This is about as well as you'll ever see it. Let's look at a different image though. Now you see the anterior scalene muscle with a needle in it. Somebody's doing a scalene block. And you see the brachial plexus, and right next to the anterior scalene muscle, another gray blob, is a middle scalene muscle. Now it's a lot harder to separate those muscles from each other and to separate them from the brachial plexus. So let's look at another image. Another CAT scan. Here the anterior scalene muscle and middle scalene muscle are inseparable. They're just one big muscle mass. And while I've pointed to the brachial plexus, I don't think you can really see it or assess it in terms of enlargement or abnormality. So what else do we have? Well, let's take a look at MRI. Here's a beautiful MRI image from one of our patients. We see the anterior scalene, it's a dark gray. We see the white fat around everything. And we see the brachial plexus is an intermediate gray. We can distinguish those. If you look on the other side, you'll probably be able to see three parts of the brachial plexus, and it's surrounded by white fat. Very nice picture of the scalene triangle. Let's take a look at another MRI image. Again, the anterior scalene, the brachial plexus. We can actually follow one of the roots of the brachial plexus, in this case T1, coming out of a neural foramen. It's dark gray coming out of the spine on each side, heading towards the scalene muscles. So MRI shows the differentiation between the muscle, the nerve, the fat, the bone quite well. Now I'm going to go back to this just so we refresh our memory. There's the anterior scalene, and there's the scalene triangle. MRI can also do this. A different plane. We see the anterior scalene. We see the scalene triangle, which is the white fat triangle. And we see these gray streaks, the brachial plexus, beautifully. So I don't think it's hard to tell which imaging mechanism I prefer. Now, I'm showing this one again, either because I accidentally copied the slide or, okay, that's it. So instead of imaging the anterior scalene, let's get to the meat of what we're talking about. Why is the anterior scalene the key to TOS? First, the anterior scalene is what I call an anchor. You can find it in every patient unless it's been surgically removed. Once you know some basics of your anatomy, you can find this muscle, and then you can find the structures around it. The most important ones being the subclavian vein in front of it, the subclavian artery and the brachial plexus behind it, and then further back you see the middle scalene muscle. Below the anterior scalene you find the first rib, which is usually fairly hard to find on an MRI. Then we need to know that there are multiple anatomic variants of the brachial plexus and of the anterior scalene muscle. We're going to talk briefly about blocks, anterior scalene blocks, and I want to remember there are multiple types and multiple causes of TOS. So while I call the anterior scalene muscle the key, it's not always the answer and not the sole answer. All right, we look at this one again. Simple, anterior scalene. We always look for that one. I do, even after reading thousands of these studies, always find the anterior scalene first. And then I can find these other important structures in relation. Okay, here's an anatomic variant of the anterior scalene. You see the anterior scalene, you see the brachial plexus. I've labeled both of those. We see a small muscle. Sometimes it's small, sometimes it's larger, called the scalene minimus. Sometimes this arises from the spine. Sometimes it arises from the anterior scalene muscle itself. Sometimes it inserts on the first rib or on the lung apex, on the soft tissues. So what we see here is it's actually splitting the scalene triangle. Normally there's space there for the artery and the plexus to go through. In this case, that space is split. It's cut in half on each side. And you see that the plexus and the subclavian artery in red are split. Here's a paper by Koh. Sorry, I don't know why I jumped over that one. Okay, so this is a paper came out not too long ago when he describes something that we've looked at for years, which is the variant pattern of the brachial plexus. On the top left, you'll see a very normal pattern. We have 5 nerve roots, C5 through T1. They branch, they split, they form this network, and they pass between the anterior and middle scalene muscles. But as you look at each successive image, you'll see something different. The second image on the top row, from the left, you'll see the C5 nerve root, is crossing anterior to the anterior scalene muscle. I see this in a decent amount of patients. It's important for the surgeon to know. It also helps explain why some symptoms change between different patients. The next image over shows both the C5 and C6 nerve roots passing anterior to the anterior scalene muscle. Again, if you focus on the anterior scalene muscle and then you go looking for the nerves, you'll have a much better chance of finding them. And then the bottom 3 just show varying forms of nerves penetrating the scalene muscles, which I see quite a bit on MRI imaging. And sometimes even the lower right image, where the scalene muscles are just totally inseparable. It's just a big, solid muscle mass. Now you can imagine with the 3 on the bottom row, if you injure that muscle, if you got a strain or a micro tear, how that could directly affect the brachial plexus because of its unfortunate location that you were born with this pathway, anomalous pathway of the brachial plexus. So this is a different type of TOS than you would get when the clavicle compresses the plexus against the rib. Here's an MRI image where you can't see on either side a clear separation between the anterior or middle scalene muscles. It's just a big mass. And you see on each side, the gray brachial plexus is just squeezing right through the center of that complex muscle. This is one of those sagittal images. Here's the anterior scalene, but you'll also see these gray streaks. These are C5 and C6 nerve roots passing abnormally through the anterior scalene muscle. And here's one where you get a scalene minimus muscle that just shouldn't be there, and you can see how it narrows that space at the bottom. On this one, each brachial plexus looks like a snake kind of winding its way through those muscles. There is no scalene triangle in this patient. It's just one solid mass of muscle. So these nerves are going to be prone to irritation if the muscle gets damaged. Also, if you move your arms, these nerves are not going to glide so easily. They're kind of trapped and tethered within these muscles. That's why it's so important to know this. All right, so that's the big overview. And now I'd like to take questions as we get them, Herb. All right, TOS and Bound, we saw your comment in the very beginning. I appreciate that. I'll read it. It's important to mention that while the anterior scalene muscle might be the problem, it's not the solution. When the clavicle falls from thoracic flexion and rounded shoulders, it puts more stress on the first rib. So let's dissect. I hate to make a pun out of this, but let's dissect what you're saying, which brings up a lot of good points. Number one, the anterior scalene is very helpful in a lot of ways to understand the muscle, to understand what it does, where it's located, and a lot of these variants of the muscle or the brachial plexus. That's really helpful for a doctor like me to help diagnose the condition. Secondly, it's not the answer by itself. I absolutely agree with that. We know that there are many different types of TOS, and therefore it's not always going to be the anterior scalene. Some patients will get a scalene block. I'm going to discuss that briefly. I have thoughts about that. But the reactions in different patients does not mean that the patient should go to surgery. Now, I know that counters the literature. Most of the literature written by surgeons says you do a scalene block. And if the patient responds with decreased pain or decreased symptoms of any sort, it's a good sign to go to surgery. I don't think that's true. What happens is if the TOS injury itself, let's say a motor vehicle accident injury or overuse, stresses the anterior scalene muscle, then like every other muscle, when it gets tight, it starts contracting to find a new place where it's less painful. But as it does that, you have to change the position of your neck forward, and often your shoulders will roll forward, which is what TOS Unbound has referred to. Now, that rounding of the shoulders is often a secondary response to the underlying pain. When we examine patients in an emergency room with abdominal pain, one of the things we look for is guarding. Like if you touch a part of their belly down in the right lower quadrant, do they wince and pull away? They're protective. The body is protective against pain. So this rounding of the shoulders and this forward flexion of the neck is often a response to those anterior scalene muscles being injured. They're trying to find a new equilibrium that's less painful. But what happens is it's a vicious cycle. If the muscle is injured and it squeezes, contracts, then it gets more painful and then it contracts more. So we have to break that cycle. That may be part of the reason that scalene blocks reduce symptoms. Now, some people, when they do scalene blocks, and I'm sorry, TOS Unbound, you opened up a can of worms, so we can discuss a lot of different things here. Some people will do a scalene block with lidocaine, a short-acting anesthetic that lasts 10 or 15 minutes. They may do it under ultrasound. Some people do it unguided. Some people do it with CT guidance. And what they're trying to do is inject a very tight muscle with some of this liquid. Now, I've done them myself, and oftentimes patients feel better. Question is, why do they feel better? Some of the theories out there say, well, if you relax the anterior scalene muscle, it'll allow the first rib to drop, and that resolves the compression between the collarbone and the first rib, which is another thing TOS Unbound has referred to here. So, number one, we have no proof, no evidence that injecting that muscle relaxes it. Yes, it's possible. How fast does it relax it? How much does it relax it? Nobody knows. Does the first rib drop? Well, my viewpoint is you've got a very flexible cervical spine. The scalene muscle starts here and inserts on your first rib. If you relax that muscle, my guess would be that the flexible spine is going to swing upwards rather than the first rib dropping. Your first rib is attached to every other rib, a total of 24 ribs and a breastbone. And that's a big, heavy structure with lots of muscles. If you're going to raise that structure, you're going to need an awful lot of muscular strength. And I suspect that relaxing the scalene muscle, even if it occurs from an injection, allows the neck more freedom of motion rather than letting the first rib drop. Okay, so there are no studies that prove that. Some people will inject the anterior scalene muscle with Botox. Botox does something called chemodenervation. It prevents the nerves that go to the muscle from acting on the muscle. It's just a block right there at the neuromuscular junction. So the muscle doesn't receive any signal and it starts to relax, and then it actually gets smaller in size if you wait long enough, and that can have a beneficial effect. Now, again, we don't know why is the pain being generated primarily from the anterior scalene muscle. If you numb up the muscle, the pain goes away. Maybe it's just that the muscle is generating a spastic pain signal. Or does relaxing the muscle allow the rest of the shoulders and neck and collarbones to assume a new position? So there's not much proof of this either way yet. But clearly, lidocaine blocks, Botox blocks do have an effect. It's kind of striking. Whether it's an indication to go to surgery, I have my reservations on. But what I do know is sometimes we use that for patients who are going through physical therapy because it allows them to assume a new position and to stretch ever so much more because of the decreased pain and the increased flexibility. Okay. So thank you. I hope I've answered a bunch of your questions. It's really a very complex question you asked with multiple points. Jimmy in Seattle says, I know you do MRI for TOS, but do you also do office consults? Jimmy, thank you for the question. So here's how we help out. We don't see patients directly. I am board certified as an internist, but I don't practice internal medicine anymore. And certainly having gone through the training helps me understand what other doctors are looking for, but I don't practice and I don't see patients directly in my office. We do offer a half-hour consult service where I'm happy to discuss securely with a patient their medical records so far, the images that we have, and what kind of steps they can take, whether they are likely to have TOS or not, and then which doctors they can go to for a direct physical examination, clinical question, and history taking. So I would not stand in the way of some of these experts out there who are TOS specialists and see patients directly, but I do provide a consult service. Reach out through our website. We're happy to talk to you more about it. Jenny in Boston. Hi, Jenny. I'll have to watch this again. I'm so confused. I'm really sorry. I tried to repeat a bunch of things because we use medical language so much and the anatomy is complex, so I apologize. She says, do you know a clinician in the Northeast that sees TOS patients? So yes, we know several. Actually, in Boston, there's a great guy named Dean Donahue at Massachusetts General Hospital. He's a surgeon. He has a ton of experience with TOS, seeing patients and doing the surgery. If you're willing to go to New York, there's some great docs there. I would ask you reach out to us through the website, tosmri.com. Go to the last menu on the right, and then you'll find contact us. Send us, just fill out a form, and I'll send you a list of docs and their contact information. Thanks, Jenny. Oh, and watch again, and then let us know or ask questions either through our website or through the comments on YouTube. By the way, at this point, I'd like to stop and ask everybody if you'll either subscribe to us or hit the like button. So we do this because we love TOS and try to help, but I understand we want to spread our word farther. So spreading the word farther, I have to ask people to subscribe and click like. So please click like. All right, Linda in Fresno. So nice. She says, I love this channel. The videos are so helpful. Thank you so much. I only have TOS on the right side, but I feel like it's also on the left side. Is that normal? That's a really good question. I would say that from all my conversations and my connections with doctors, TOS, when it occurs, and it's genuinely TOS, tends to be bilateral, either bilateral symmetric or bilateral asymmetric, or one side is worse than the other. And frequently, you may be right-handed. It's the dominant side, the side that you use most often to reach for that knife, the side you use most often to pick up the phone or to turn a radio on. So people use their right hand more than their left if they're right-handed. And because they use their right hand more, right-hand dominant people tend to get it more on the right. And here's another interesting phenomenon. People who have no symptoms on the other side get surgery. They feel better on the first side, and then they develop symptoms on the second side. Now, that may be due to a number of things. Either the balance of their neck and shoulders is different because part of the rib has been taken out, or scalenes have been taken out, or maybe they're just doing more because they're not inhibited by the pain and the struggle anymore. But generally, I think people with TOS, because the way their body is structured, and I think there's clearly a disposition some people are born with, they clearly have it either both sides or both sides asymmetric, where the other side is hidden and masked, but can come out and become worse. So if you develop symptoms on the second side and you're happy with the doc on the first side, Linda, who did the surgery, or I don't know if you've had surgery, but if that's the case, then you should be examined. And again, we think our MRI clearly shows the anatomy that can cause and contribute to TOS. Thank you for the good question. John in St. Croix. My symptoms didn't begin until I fell in the kitchen and landed on both hands. Could that have caused my TOS? Yes. We hear that story a decent amount of patients. Sometimes it's a car accident. Sometimes it's people falling off a bike. Sometimes it's people who fall. Sometimes they land on one outstretched shoulder in athletics. Sometimes they fall directly and they brace themselves with both arms. But I would bet that you have an underlying predisposition. In other words, Maybe some of your spaces are sort of borderline narrow to start with. Maybe you're more flexible than normal. But this one extra trauma just took away that little bit of reserve that you had left and caused the symptoms. So see a doc or talk to a doc who's experienced in TOS. Reach out to our website. We can send you links to docs that you can connect with over the internet. Debbie in Texas. Hi, Debbie. John just mentioned his fall. What about car accidents? I feel like my symptoms are connected to being rear-ended. Well, the rear-end motor vehicle accident is one of the most common causes of TOS. Debbie, we see that in so many cases. The head is on this short stick or broomstick of a cervical spine. What happens is the body is pushed forward. The head and the arms, you can imagine, are kind of driven backwards. And then you hit the headrest and everything is driven forward again. Or an airbag comes out and stops you and the head comes forward. Now, when your head goes back like that, all these deep muscles try to stop that motion. They contract suddenly. But in a rear end accident of any decent speed, there's too much force and those muscles get micro tears. Now they're injured muscles, they're throbbing, they're painful, and they start contracting. And that leads to situations like TOS Unbound mentioned, where an abnormal anterior scalene muscle may not be the whole answer. But if it's tight enough, it can bring the shoulders forward and bring the collarbone down towards the first rib, which doesn't move very much. So yes, rear end motor vehicle accidents, common cause of TOS. I'll bring up one more point. You all may have heard of whiplash or soft tissue injury of the neck. These are things attorneys deal with, and it's very hard for them because there's not a lot of stable criteria for diagnosing whiplash. But I believe that many cases of whiplash, especially if it's not local, if it's not just neck pain, but it radiates to the arms, I think those cases are not whiplash. I think they are thoracic outlet syndrome. Okay, next question. Hey, Jay Spence says, please hit the like button. Everybody hit the like button. I love that. All right. Hey, Jay Spence, could you discuss or explain how and why scalene muscles and TOS play a part in limited ability for expansion and deep breaths? Great. So go back and check the talks that Steve Talikowski has given for some helpful points. The anterior scalene muscle starts along several of the cervical spine bodies, 4 of them usually. Remember, there's a lot of variation. Still, it arises from multiple points in the cervical spine. Then it attaches on the first rib in front of the other scalene muscles. And there's one more muscle called the Sternocleidomastoid, not a part of TOS, but it starts back here, something called the mastoid process, and it goes here and attaches to the collarbone and the breastbone, the upper part of the breastbone. You can feel that muscle. If you turn your neck like this, very superficially, you can grab that muscle. Now, if you have trouble breathing for any number of reasons, for example, would be asthma or emphysema. Watch somebody who's having an asthma attack. Instead of breathing like you and I, their chest rising and falling, they'll be using their neck. They have the posterior muscles in the neck, stabilizing the neck. And then the sternocleidomastoid and the scalenes, much deeper, are trying to pull up that first rib and get more air into the chest. Emphysema and asthma both do what we call air trapping. Air gets into the chest, but it doesn't get out, not very easily. So what happens is you're way at the end volume. You can't expand your chest very much more, but you need to get air inside. So that's why these accessory muscles, the anterior scalenes, sternocleidomastoids, start working overtime. They're not intended for this, in my opinion. It's a secondary function, but when you need to breathe, and you recruit all the extra muscles you can. So if it happens, and I hope this doesn't happen to anybody here, but if you do see a friend or a family member having trouble breathing from asthma, let's say, you will be able to see their neck muscles working. All right. Make sure they're being seen by a doctor at that point, by the way. All right. Thanks. Jay Spence says, I experienced this. So without getting your medical history here, of course, you could have asthma or emphysema, or, sometimes people who exercise really hard, you'll see the neck muscles going. So I don't know if you're a marathoner or a rock climber, maybe you're a mixed martial artist, but when you really push yourself, you will use those accessory muscles to get more air into your chest. Christoph, hey. Hi, Dr. Werden. First, thanks for your talks. They raise awareness and knowledge about TOS. Much appreciated. Thank you very much. We think you all can help raise awareness, spread awareness, let people know this is a real disease. And then if injection relaxes the scalenes and it helps, wouldn't a cervical collar or a support device for the neck do the same thing and be used as treatment? I'm going to tell you right up front, I don't know. I've not seen any of my TOS docs actually use that. But it is a good idea because what we're trying to do is to get those muscles in the front to relax. It's a really good thought. We want the neck not to flex so much. Flexing is this forward bending. And so I think when you get the neck collar on, I've had it a few times, your muscles relax. You tend to relax. Your head, you tend to, like on an airplane, if you have a big cushy pillow, it just kind of lolls from side to side. So I don't know the answer to that, and I can't remember seeing it in the literature. I'll bet you, though, it's in the literature, just not pulled out separately, because patients with quote-unquote whiplash, part of their treatment is a cervical collar. So I don't know. I'm going to ask some of my local docs, and next talk, I'll come back and answer some more of that question. Or if you want to email me, I'll just email you back when we get some more. Thanks. Hey, Buddy Lee and me. Brad Simpson. I know it's not the scalene, but how important is the subclavius muscle in collarbone depression? Any way that healthcare professionals treat it? So, Brad, you know what? You and all the other people who are asking questions today, I can tell you 20 years ago and 10 years ago, we would not have had patients like this. So kudos to everybody for being so smart and understanding more than just the basics of what I talk about, for asking next level questions. That's really good. So the subclavius muscle. Subclavius muscle is a small muscle. It parallels the collarbone. It rides underneath the collarbone. It starts here with a tendon, the subclavius tendon, that starts from the first rib cartilage. And then that tendon can be small or large. And then the muscle belly rides along the underside of the collarbone, and it inserts on a part of the shoulder blade back here. Now, my guess would be that it's meant to absorb shock to prevent the collarbone from fracturing more often. We see a lot of muscles in the body that help the skeleton stay healthy. The skeleton by itself, if you don't have muscles supporting it, will crumble. It's an amazing substance, but muscles help balance the loads. And I'll bet that's what the subclavius muscle does. I haven't read on it, and I will do some reading. I'll bet you there's some papers out there on its function. Where it does contribute to TOS, though, is the size of this tendon up here may be small or large, just like we see the anterior scalene. It can insert on the first rib nice and narrow or very wide, or even in multiple different places. So with the subclavius muscle, it so happens that the subclavian vein goes right underneath here, underneath the tendon of the subclavius and over the first rib cartilage. And we believe, a lot of us do, that compression of the vein, even if it doesn't give you a blood clot, which is venous TOS, even if you don't get a blood clot, compression of that vein may slow down blood coming back from the arm. And the arm may always be a little bit swollen because the fluid is not draining out. And we believe that fluid building up within the nerves can contribute to or cause the nerve problems of TOS. So yes, it is important in TOS, but that's the only way we know of it right now. Also, we can see that sometimes when you raise your arms, the subclavius muscle gets quite close to another muscle in the chest and can compress the brachial plexus. But in those cases, there's almost always compression between the rib and the collarbone, which are two hard surfaces. So yeah, it's a really good question. Thank you, Brad. Benjamin Butler. Hi, can neurogenic TOS cause persistent skin and nail discoloration or just intermittent? Is this sympathetic nervous system? You guys are killing me here with these great questions. I love it. Okay, Benjamin. Yes, there is abnormal blood flow in a subset of patients with TOS. Some patients are known to get temperature changes. Their hands become cold. Other patients will get, if they have chronic abnormal blood flow, they can get what we call atrophic changes, meaning not enough nutrient going to the nails and the fingers. They'll lose hair on their skin. The skin will smooth out. Their nail beds can become abnormal. Sympathetic nervous system is absolutely correct. What we believe happens is that there is, in some patients only, more predominant involvement of the sympathetic nerves. Now, let me explain this to our other listeners and viewers. The body has three basic nervous systems all wrapped into one. There's the motor nerves. The motor nerves make muscles work. They tell the sweat glands to make sweat. They tell the blood vessels to contract and raise your blood pressure in a certain area. The sensory nerves gather information from the body. They gather pressure information or pain or burning or stretching or pain in the bowel. So those are the sensory nerves. And the third type is what we call the autonomic nervous system. Autonomic, it runs on automatic. It's a subconscious nervous system. When you get excited, you watch a movie that's got a thrilling scene, your heart beats faster. That's because nerves from a deep primitive part of your brain tell the heart to beat faster. Or they tell you to sweat when you get scared, or they control your blood pressure or your breathing. So this autonomic nervous system consists of two divisions, sympathetic and parasympathetic. And I'm guessing Benjamin has some experience in the medical field, maybe not, but it's a really great question. Some patients get the sympathetic nerves involved more than others. And there was a study in the early 20th century, 1912, I think, a guy named Todd found that some patients that he dissected, not patients, but cadavers, of course, he had dissected, and he found that the sympathetic nerves were clustered off to the edge of one of the nerve roots and that they were more prone to being compressed or stretched in TOS patients. So I think there are patients who do have this variable distribution. The sympathetic nerves can be affected more than other nerves, and patients can, yes, get abnormal blood flow, sensations of cold or hot, and chronically atrophic changes where the skin and hair and nails will change. It should not be intermittent. You can get, though, compression of the large blood vessels here when you move your arms. That would be an intermittent change in blood flow. So some doctors will do a saturation test. They put a little soft clip on your finger and they measure how much oxygen is in your blood from 0% to 100%. Most people here are not going to have 0%, obviously, but the difference between 90 and 100% is a pretty significant difference. So some docs use that. That's really measuring the end result of large vessel compression and small vessel compression. And I hope that answers your question. If not, feel free to ask a different part of it and I'll chew on it again. Stephen. Hi, Stephen. Good to see you again. What are the drawbacks of a scalenectomy? Does this cause vulnerabilities, limitations, or stresses on other structures? I'm not surprised, Stephen, you'd ask a great question. And I have to say that in the literature, I think most people who do scalenectomies, surgeons, don't believe that there are long-term consequences. But I do not know of a paper that has evaluated that. In most cases, patients who go to scalenectomy are having severe enough pain that they're willing to risk a long-term complication of maybe weakness or limited mobility to get rid of the pain. And I understand that. So I don't know that somebody will study it in the future directly. However, we could guess at certain things that it might make it harder to flex your neck with force. It might cause an imbalance where the other scalene muscle does too much work, and maybe that leads to early degenerative changes because all the joints in the neck, and there's several different types of joints, but joints in the body will wear out if you use them asymmetrically. So maybe it leads to early degenerative change of the neck. I don't know. But other than that, assuming no surgical complication, I do not know of a long-term complication from having a scalenectomy. Now, the process of scalenectomy itself, there are potential complications. One of them is nerve injury. This is a muscle that rides with a phrenic nerve just on the top of it, a small nerve. The phrenic nerve controls how your diaphragms move, and that controls a lot of your breathing. If the phrenic nerve is injured, or even if it's disturbed and it goes into what we call a palsy, where it shuts down for 2 weeks to 6 months, that can severely affect your breathing and make it hard to breathe, especially if you have any exertion at all. So surgeons are very careful around that phrenic nerve, but it does ride right along the top of the anterior scalene muscle. So a scalenectomy could potentially disturb that nerve. There's also the brachial plexus, which, as we've seen, can go through the scalene muscles, around the scalene muscles, behind, in front. And so cutting the muscle away can disturb those nerves. And in addition, many surgeons will do a neurolysis, what they call an aggressive neurolysis, stripping off scar tissue from the outside of the plexus. And I'm not sure if there are complications to that. I've seen many cases post-op where the brachial plexus is inflamed and the patients have persistent symptoms. But there's no solid pro and con, no pre-op and post-op comparison on most patients to do a study on that yet. I think that'll change soon. We're working on it. And then there are other structures like large veins and arteries around the scalene. It's very rare that a good TOS surgeon will cause damage to those structures. Rarely, patients can get an air leak around the top of the lung, a pneumothorax, during a scalenectomy. Those are usually treated pretty easily as long as they're recognized. And sometimes on the left side, you can get a leak of the large lymph vessel. Lymph is a low-pressure drainage system, and the large duct empties into the left subclavian vein. Rarely that can get injured, and you build up with kind of a milky fluid in the left chest. Again, it can be treated surgically. It just has to be recognized. So thank you for the good question, Stephen. Hi, Danny. Good to see you. Could the scalene muscle be what causes my neck to feel like it constantly needs to crack or pop? So, dude, I'm not a real good expert in cracking and popping of the neck. I hate it when mine does that, but when you get to a certain age, it does it a lot. The scalene muscle is, if it's abnormal, it's going to change the position of your neck. It's going to put you in pain because your neck does not want to be twisted and pulled forward. And your shoulders, as we had our original person who, TOS Unbound, asked us about that. So rounded shoulders will be one way that you move the collarbones forward and help you shorten the neck muscles. So there have been some studies, two that I know of, where they use electron microscopes to study injured anterior scalene muscles. And they found that those muscles had permanently changed. Normally, there's a mix of a thin amount of fibrous tissue, like a skeleton, to support the muscle cells. And there's a mix of muscle cells, types 1 and 2, fast twitch, and slow chronic pullers. And so they found these anterior scalene muscles had too much of the type 2 muscle fibers and too much of the fibrous tissue. So they clearly had changed chronically from being injured. So we know that there are change microscopically on the cellular level in the scalene muscles after an injury. It doesn't happen in everybody. But my suggestion is you need a good TOS specialist who examines you, who knows this, who has seen this a dozen times or 100 times, and can help try to separate those things out. It's not something I do directly. I read about it all the time, but I would refer you to a good doc, like a Dr. Jenkins in New York, like lots of other docs we know. And you can raise that question. All of you should be confident to raise questions with your doctors. If you say, I read this on Google, I researched these papers, I watched Dr. Werden even, that may get you into trouble. But if you have a doc who says, get out of my office, I'm not going to listen to Dr. Google, then you're at the wrong doc. That's my opinion. The docs that we work with around the country, when they get patients coming in asking questions, sometimes they ask me that question that the patient asked them. And you know what? All the good docs for TOS don't know everything, myself included. I'll put myself at the top of the list. I have so many papers I'm trying to read and so much stuff that I haven't answered yet. So a good doc will work with you. This is where we live today. TOS is a disease that's been challenging for a long time, but we're making really good progress, partly because, as was raised before, we're getting increasing awareness now. We have, high-end Major League Baseball pitchers being diagnosed with it. I posted now on my blog, my first 3 blog posts after redoing our blog were all about baseball pitchers. So we're starting to get that awareness, and that means patients are getting to doctors sooner. It means doctors are more aware. So a doc will do tests that he or she knows of, and if they don't know the disease, they'll refer to somebody who does know the disease. So we're definitely making progress. Don't be afraid to ask your doc questions like that. All right, thank you. Jay Spence says, I'm a boxer. So actually, there was a very interesting article in the New York Times, I believe, that they were asking ringside doctors in mixed martial arts, when do they stop a fight? And these docs, they're smart people, but they're, it was a very interesting article that's totally unrelated to TOS, but it was fascinating because you got 2 guys or 2 gals in the ring, pounding each other as hard as possible. I don't know how, as a doc, you try to stop that because, if it were a friend of mine being hit, I'd jump in right away. But you can't do that with boxers. So Jay Spence, you're a boxer. Theoretically, you could easily get twisting injury from being hit, and the scalene muscle is part of the resistance to that. And if it contracts and tries to stop that impact, it could get micro tears. So while it's not commonly listed as a cause of TOS, I would not at all be surprised if someone's who's hit enough in the neck, or maybe you do training exercises that really stress your neck, or maybe you're doing mixed martial arts and you're getting your neck twisted as part of a bout. I would not be surprised if that could cause TOS. And it's a really good question. No one's asked me that before. Brad. Yes, this is our website, tosmri.com. We're always putting new things on. Please go there. Please spread the word. When you go read our blog posts, tweet them out or put them on wherever you go for your social media and help us spread the word. And Brad says, can you get better with TOS if you have muscle atrophy? That's a great question. If the muscles of your hand are starting to atrophy, that means that the motor nerves, some of the deepest and most protected nerves coming from the neck, are probably being damaged. You do not want to get to that point. Okay, those are the muscles that'll atrophy first, meaning they'll get small because they don't have enough nerve signal. It's been shown clearly for all types of entrapment neuropathy, and TOS is an entrapment neuropathy, that once you get motor damage, that you have to act as a doctor quickly because it's usually not reversible. As an example, when you get an L5 radiculopathy, meaning one of your lumbar 5 nerve roots gets pinched by a herniated disc, any doc who knows what she or he is doing will test the strength of those muscles, usually that you can stand on your toes, okay? And if that's weak, then they'll go into surgery. And if it's not weak, they'll say, it hurts, but I'll give you some pain meds and let's ride it out. So atrophy or weakness of the muscle is a bad sign. You don't want to get to that point, okay? You want to get surgery and relief before then. All right, thank you for the good question. Buddy Lee and me. No matter how much or how long a knowledgeable physical therapist or chiropractor works to correct TOS, it can never go away 100%, can it? So I'm the wrong person to ask for this, I believe. I'm always asking around. I check on individual patients, try to follow up. TOS can be gotten to a completely manageable point in the right patient. We had a musician several years ago brought to us a local hand surgeon, called me from his examining room. He had a mom and her son, and he said, I'm going to connect you with so-and-so, Scott. I think the kid has TOS. The kid had a music scholarship, and he couldn't play his instrument. And he did have TOS, and we got him help, and he did much better. He opted out of surgery. He uses the specialized vest that Dr. Tracy Newkirk makes, and he uses it just when he needs it. He finished college on his scholarship. He ended up playing with some pretty famous people, and he's, as far as I know, in Nashville, working in the music biz. And so he knows when the onset of symptoms is very early, and he protects himself either through postures or relaxation techniques or breathing techniques. He wears the vest when he needs to, and he says it's more than 90% controlled. So I think that the primary thing would be, is it a primary soft tissue abnormality that we can relax and treat? Or is it a bony abnormality? The bones won't change much in size. Now, the collarbone comes down against the first rib. It's a common cause of compressing those nerves. If you can change the position of the shoulders, you'll change the position of the collarbone, and that may relieve it. But in some patients that we see, it's just very, very narrow between the rib and the collarbone. Most surgeons I work with say, at this point, you can try to take 6 weeks, see if we can make any improvement with conservative therapy, but I'm leaning towards surgery. So it really depends on what's the causation in each individual patient. That's the starting point. And then the next would be how good a team you have working with you, and then how self-disciplined you are. Thank you. Jay Spence, that's not good. I've had 3 car accidents from the left side. So you've been T-boned from the left side 3 times? T-bone accident can cause TOS. It's different than a rear end motor vehicle accident, but it has some of the same effects. When you're T-boned, your body's going to fly this way, and your neck and head are going to go back. They're not going to be brought forward as fast. So this muscle gets injured from contracting tightly, and then your head will fly the other way, and this scalene muscle will contract tightly. So it's possible to get both scalene muscles in a T-bone accident. But having 3 car accidents, if there's any decent velocity, like 20 miles an hour or above, I would make sure you see a TOS specialist. Certainly could put you at risk for TOS, Jay Spence. TOS Unbound gave us our first really good questions. What do you think about the superior angle of the serratus anterior's attachment to the first rib in regard to its role in TOS. Okay, so you put me in this position of, you know what you're talking about, and we have all these other people watching who are asking, what's the serratus? What's the superior angle? So I'm going to start off trying to explain some of that away, even though I got the feeling you know what you're talking about here. The serratus anterior muscle is a fairly large muscle. It rides across the top of the first rib, kind of bulges above the top of the first rib on each side posteriorly. And then it drops down around the back of the rib cage, and it inserts underneath each shoulder blade on the inside. What it does is when it contracts, okay, it can pull the shoulder blades, okay? So it can pull them backwards towards each other. The serratus anterior. So it also has multiple attachments to the rib cage. So what it actually does is it pulls the shoulder blades forward, So it starts at the ribs, goes down the back, around the chest, attaches to the ribs, and then when it contracts, it shortens the space between the anterior ribs and the posterior margin of the scapula or shoulder blade, and this tends to protract or pull the shoulder blades like this forward, so you can roll your shoulders forward. Now, as far as I know in TOS, I don't know that there's a lot of study on abnormality of the serratus anterior muscle. When I do MRIs, clearly the plexus in some patients can ride over that muscle directly, and in some patients, the space between the serratus anterior and the subclavius muscle underneath the collarbone can narrow tightly and press on the brachial plexus, which of course could cause symptoms by this compression, or it may not allow the plexus to glide normally, which may cause tension on the brachial plexus. In some patients, we do see that there's an atrophy or asymmetry of the serratus anterior. The nerves that serve the serratus anterior come from C5 through C7 nerve roots. They branch off early, so it's not directly an injury of the brachial plexus that can affect those nerves to the serratus. Can also be other problems because they actually go through the middle scalene muscle, usually as the long thoracic nerve. And that nerve can be one nerve, or it can be two or three or more bundles of nerve. Surgeons often tell me how they find it's a very variable nerve. It penetrates the middle scalene muscle at multiple points sometimes. So it's possible that injury of the middle scalene muscle or overuse could compress this long thoracic nerve and those three nerve roots and make an abnormal function or size even of the serratus anterior muscle. I hope that helps answer your question. If not, ask again a more detailed question. I'm glad to address it. And Jay Spence says, also, who was the person you said to check out about breathing and its relation to scalenes? That's right, Steve Talikowski. So he's done several videos here. We can find them, or reach out to me through the website. I'll send you his contact info. He's glad to talk to TOS patients. His name is spelled Talajkowski. And don't ask me to repeat that. I'll probably get it wrong. Thank you. Cindy says we need a cure. Well, I'll say this, Cindy. It really sucks for TOS patients. Some of them have really gone through hell. I don't like that. We are doing our part to help build connections with docs who are good TOS specialists, patients with each other. We think that's really important. Our imaging, we're really trying to do the best thing we can to help understand any single patient, but to also see the trends. What do we see the most on, if I do 100 scans, what am I seeing a lot of? What do I see a little of? And then finding out when we do a scan, how does a patient do after treatment? Maybe there's a different type of treatment for the different underlying causes of TOS. In some places I know, and I don't want to be critical, some places go ahead, they'll do a scalene block, a clinical exam, and they'll go to surgery. And I personally have trouble with that because I know that we can show so many things. And I know that there's 20 different types of TOS from the medical literature. So if it were me, if it were my family member or friend, I'd say get the imaging. There's no radiation to an MRI. You get the imaging, you know exactly what's going on in there. And then a surgeon can say, I need to do this or I need to do that. And maybe it's not even surgery. Maybe it's conservative therapy. Maybe it's a mix of the two. So yes, we need a cure. Yes, we need to get that cure. We can do it by getting earlier awareness. When I first started at this, I met patients all the time who had had symptoms for 10 years, 20 years, and no doc would believe them. Then when you do surgery, they get some improvement, but not a lot. We need to get to it early. So that's why we're doing more blog posts, why we do these live streams. We don't accept advertisers. We're just doing it because we believe there's value in creating a central hub. People can come to our website and learn more about TOS, see the videos, find out who the other docs are who do different things. There's a neurologist who diagnoses it differently than the spine surgeon or than me. So so everyone, help raise awareness. Hit the like button here, subscribe to us, go to your social media channels, add our videos, add our blog posts, and let's keep spreading the word. Cindy says, I had my first rib removed. I want to hear more about that. Cindy, was it on the side that you're dominant? In other words, if you're right-handed dominant, did you have TOS on your right side or on both sides? And did you have the surgery on the right side or the dominant side? Please send us back. TOS Unbound, Danny Davis, he says, it could be popping where the first rib meets the spine from long-term stress on the first rib. So people get degenerative changes at joints all over the place. There's a couple of joints back where the rib meets the spine. One of them was where the head of the rib actually joins up against the spinal body. Another one was where the neck of the rib rubs against the transverse process of the spine. Recently, there's a baseball pitcher who was taking some time off because, it was a hitter. It was Trout. And he said, I have a super rare back condition, but I don't think it's super rare. I see these degenerative changes in a lot of patients. Popping can come from a lot of places. I think that's a good mention here. But, a good doc can examine you and put his or her fingers over the different spots and try to figure out where the popping is arising. Yes, it can come from a degenerated joint. It could come from a joint that's kind of slipping a bit, but not totally dislocated. So yeah, a good physical exam can help diagnose what the joint in question is. And I'll say this, oftentimes a joint that pops doesn't cause pain. It may not be the pain generator. And there are ways to test for that. So thank you for the comment, TOS Unbound. Appreciate that. Benjamin Butler says, thanks, perfect reply. I'm trying to remember which reply I made, so bear with me. My brain isn't good as it used to be. I'm a chiropractor. Great. In brachial plexus, is lower trunk compression more common? Do the upper trunk brachial plexus be compressed between the first rib and the clavicle, or just the interscalene triangle? Great. Okay. Good questions. So number one, as a chiropractor being aware of TOS, that's a super combination. We at Vanguard Specialty Imaging know some good chiropractors, and we find that oftentimes they make diagnoses that maybe some docs didn't make. There's a lot of hands-on time, and there's a lot of observation in the good chiropractors I know. So I think they're a valuable member of the team. Secondly, if patients sometimes get a combination of chiropractic and physical therapy, along maybe massage therapy or injections, selective injections. So it's a part of the team. And I encourage everybody here, if you have a chiropractor who works with you, it's very valuable. Your question. First of all, there are only a few papers in the literature. I think Swank was one in the 1940s who tried to separate out upper trunk brachial plexopathy from lower trunk. A lot of surgeons and a lot of the literature tends to say that all TOS is the lower trunk, meaning the C8 and T1 nerve roots. And that's not true. Clearly, patients get symptoms in other places. The scalene anomalies, especially at the top of the scalene triangle, tends to be more constrictive around the upper trunks. For everybody listening who's not a chiropractor, a medical person, C4, C5, and C5, C6, and somewhat C7 are the upper parts of the brachial plexus. And those can get twisted around the anterior scalene muscle. They can take abnormal courses. Certainly, they can contribute to the clinical findings. They may be more involved than the lower trunks. And when you raise your arm, you're going to stretch the lower trunk, meaning the C8 and T1 nerve root more. So sometimes that's a test for determining which part of the brachial plexus is involved. C8 and T1 and the lower trunk do tend to be more involved when there's a cervical rib or a fibrous band at the cervico-thoracic junction, meaning where the neck joins the chest. There can be fibrous bands that are very hard to see on CAT scan or ultrasound, even sometimes on MRI. But those tend to get the lower trunk, C8, T1, or the lower trunk proper. So yes, there are different varieties. They can be involved differently. As I always say, there are like 26 different names of TOS over the past 200 years in the literature. And that's because different docs did different things. Put your arms here, put your arms there, sleep on your arm. And they found different results. And so they were all seeing different parts of the same disease. The reason for joining it together in 1956 is not valid. Even the guy who wrote the paper said, I'm going to combine them because it's just too confusing otherwise. But we're not dumb people, right? None of us are. especially with those of you asking good questions. So we can be more complex if it helps solve the problem. Do we need to take out the rib and the anterior scalene muscle and do an aggressive neurolysis on every patient with TOS? I think the answer is no, because there are different types of TOS. So that question you brought up is a really great question. Yes, upper brachial plexus disease is different than lower brachial plexus disease. Thank you. Oh, and by the way, all of those components can get compressed between the rib and the collarbone, absolutely. All of them can get stretched and stressed. If they're stressed out here, it's a different syndrome than if they're stressed over here, where they come out from the chest and neck. All right, Jay Spence says, I would attribute this from spending hours upon hours training on a 100-pound heavy bag, throwing left jabs. When I take deep breaths, I feel a tug on my lower left elbow and my neck strains on the left. Thanks for the information. So number one, we don't diagnose over the internet like this. It's, your personal health information. And we give general information and try to point people the right way. These are things that a good physician or physical therapist or chiropractor should be able to address with you. You can reproduce the effort, can absolutely understand why this would make your body asymmetric. I don't know if you're working your left side more because you're right-handed and your left side was weaker before, or if you're a southpaw and you focus on your left side. I don't know. But these are things, imbalance in the body that a lot of medical specialists that I just mentioned can really address with a good physical examination. So I don't want to venture there. I hope you understand. Doc, you've been solid for me tonight. Thank you. Please reach out to the website. I'd love to continue the conversation. I'm really glad that you're here viewing and asking good questions. Thank you. Rob something. Can TOS involve compression of the phrenic nerve in addition to the brachial plexus and subclavicle vein? Thank you. It's a good question. So the phrenic nerve, I don't usually see and don't usually read in the literature about patients having TOS and primary involvement of the phrenic nerve. Okay. Again, remember for everybody who's here, the phrenic nerve controls the diaphragm at the bottom of the chest that helps you breathe. If that nerve gets paralyzed or temporarily palsied, then your hemidiaphragm, one side, won't work, and you'll just always be a little short of breath. We see that a lot in all kinds of different surgery. It used to happen with coronary bypass surgery if they put ice around the heart, because the phrenic nerve would come down there and it would get frozen or very cold and it would temporarily go weak. So very often when I was early in training, we see chest x-rays where the left hemidiaphragm was too high and they had wires here, meaning they had cardiac surgery. We always put those together. So the phrenic nerve sits right on top, the forward part, the anterior or superficial part of the anterior scalene muscle. And when surgeons go in, if they're not careful, they may touch that nerve, and it's pretty fussy little nerve. It can sometimes go weak. But in primary TOS, it's not really in a place to be compressed. It goes down the anterior scalene muscle under this joint here, and then rides on top of the blood vessel on each side into the chest. So it doesn't cross the costoclavicular interval. It doesn't really go to any of the typical pain areas or compression or tension areas that we know in TOS. So I would say pretty solidly, no, phrenic nerve involvement is not a direct part of TOS, but after treatment, it can be. Thank you. Brain, a good name. I got TOS from overexercising. At what point is intermittent tingling and aching becoming permanent? In other words, how much can the nerves heal, assuming the decompression is achieved? So that's a great question. It kind of follows a little bit what we were talking about before. So thank you for that. The nerves, the little fibers, the individual nerve fibers that are in each nerve bundle, there are thousands in each of these nerves. And those little nerve fibers can be motor nerves. Remember, that activates muscles, activates sweat glands, activates blood vessels. Actually, not blood vessels so much, but it activates a lot of muscles and other motor things that make you move. It also includes sensory nerves, things that bring information back to the brain, telling my hand is cold or I just stepped on a thumbtack. And then the autonomic nervous system, a self-regulating system that controls things like blood pressure, heart rate, breathing, sweating. Okay, so those nerves are all wrapped up together in these nerve bundles, and it's a variable distribution. So depending which nerve is involved depending where it is compressed or stretched, will affect different nerves and different types of nerve fibers. And that's why in this complex bundle of nerves, when you press on it in different areas, here, 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 you get different symptoms. That's why TOS is hard to diagnose in a doctor's office clinically. So what we look for, though, is if there's any motor nerve involvement. Those motor nerves tend to be larger in diameter, and they often have a myelin sheath. It's a surrounding sheath of fatty tissue. Those things help protect that nerve from compression or stretching, whereas sensory nerves and autonomic nerves tend to be smaller in caliber, and they don't have a myelin sheath, and they may be more peripheral in the nerve, so they can get compressed and abnormal first. So oftentimes patients will get occasional numbness, tingling, pain, other symptoms, and it goes away with a change in neck position or a change in arm position, or even sleeping overnight, but then the end of the workday they get it again. Those intermittent things should be addressed before they stay permanent. But once you start getting weakness of the muscles or atrophy of the muscles, you need to act quickly so it doesn't get worse, because those motor nerves don't tend to come back. The atrophy doesn't tend to come back. It's much more likely it'll stop wasting the muscles, but getting recovery from the muscles is unlikely. So any kind of motor nerve involvement or weakness should be addressed fairly quickly. Thank you. Defying. Just recently, after doing stretches, my symptoms of paresthesia in my arms has drastically reduced to occasionally, and they seem to have migrated over to my shoulder blades and my lats. Is this normal? So is this within expected TOS symptoms? I think you are getting beyond my field of expertise. I want to be careful. We don't diagnose patients here over the internet through this medium. Without knowing exactly what you're doing, and even if I did know what you're doing, I'm not as much of an expert. I'm not a physical therapist or a kinesiologist. Those things, I hope you do have a physical therapist who's working with you, or a good doc or a chiropractor, someone who pays attention to your physical posture and the positions you assume. You can certainly make the compression of the nerves less. And if you get the muscles warmed up and relaxed, I can postulate without proof how that could open up spaces that are being affected. But I can't give you specifics. You know, obviously I don't diagnose patients here. And secondly, it's starting to get out of my field of expertise. So if you want to write to me, email me through our website, give me more specifics. I'm glad to talk with you or to connect you with somebody who does that more than me, and I can learn something good from you. Thanks. Yep, we can be reached at tosmri.com. And of course, this video is sponsored by toseducation.org, who does a lot of educational stuff for TOS patients. You can reach out to them with lots of questions. They're glad to help. Type it faster. I love that. There are some sufferers who deal with paresthesia in the leg, face, and pain in the jaw and ears. Some sufferers also have periods of difficulty breathing. Elaboration. Yes, I can elaborate. I do that a lot. Some people complain if I elaborate for too long. I think that's a great question. We know that some patients get symptoms in unexpected areas, like the legs, or like headaches, or jaw pain. So it's not just the upper extremities, and we don't have any solid proof of why this is happening. But the docs I know, the TOS docs who are aware and who pay attention to these extra things instead of trying to fit everything in one little box, they've seen this. Not a lot of patients, but some patients. So one of the docs I work with believes that the drainage from the spinal cord, the venous drainage, as it leaves the spinal cord, gets blocked up somehow. And that causes the spinal cord to not function as well. And that's why these sensations from the lower extremities pop through. And there is some evidence to that because the veins of the spinal cord in the spinal canal, the bony canal, tend to go up here and drain to the veins in the back of the skull. That's kind of a long way to go. We also know that the veins in the neck, sometimes up here due to unusual bony structures, a little larger than normal, can get compressed. And we know that the veins can get compressed here in patients with TOS. So there's plenty of evidence that the veins can get blocked temporarily, but can cause a backup of fluid and edema into the arms and other areas. I won't go through some of the medical papers on this, but it is possible that abnormal venous drainage affects the spinal cord, or venous drainage from the head and neck is directly affected by what's happening right here. So people can get venous types of TOS without a frank blood clot. We think that there's abnormal pressure in the veins when you press on them too much here, and that can affect the arms as well as the head and neck. So headaches are pretty common in TOS patients, maybe due to abnormal venous drainage or detention headaches from the muscles on the back just being tight all the time from pain. Our next week's guest, 2 weeks, August 30th, I believe, will be Rob. August 30th at 4:30 p.m. Pacific time. Good. So Rob Hagen is a peripheral nerve surgeon. This is a great question for him because he deals with a lot of these unusual symptoms, including headaches. And he's done some work at the fascia in the back of the skull, meaning this thick tissue layer that goes between layers of the scalp. And he believes that some of the nerves that pass from the inside to the outside or vice versa get trapped in this fascia. And so he can loosen up that fascia and relieve the pressure on those nerves, very tiny nerves. But he's had some very good results. And I'll ask him that question as we go through our talk on August 30th. All right. Buddy Lee and me, thank you, Dr. Scott, for all you teach us mere mortals about TOS. I'm as mortal as you, dude, really. I appreciate you coming on and asking good questions. But I really have a lot of stuff to think about because of some of these great questions. So I'm going to keep working on this, and maybe I can answer some of these questions either in a blog post or the next video we do. Ben, hi, Ben. I saw my vascular surgeon today. He did a scalene trigger point injection on the anterior scalene. I have felt great since. Is there any downside to Botox injection long-term? All right, good question. Number one, I'm glad you're feeling better. That's really good. And hopefully you're doing physical therapy and working with it, especially that you have some relief in pain now. If you weren't here early in the talk, I talked somewhat about scalene blocks. Botox in particular works great, okay? But it doesn't work as well the second and third times. I believe the mechanism, and this is a little out of my field, but the body forms antibodies to the Botox. So the second time, it tends to get chewed up a little bit. And the third time, the body's ready for it and chews it up faster. So it doesn't work as effectively on subsequent injections. It's different in different patients. It may have a reasonable effect the next couple of times, but eventually you run out of it as a tool. And so make the most use of it now. I don't know if your doc is using it as a diagnostic tool, saying this should lead us to surgery. I would give that a second thought, as I described earlier in our talk today. But you can contact me for more about that. I just tend to say caution. It doesn't always indicate a direct path to surgery. So I hope, anyway, that the way you're feeling now is a really good indicator that you've been sticking to this, I know, and that you can get better. And I hope you have a physical therapist or a chiropractor or somebody who's a kinesiologist, a body posture person who's helping you address some of the causative issues. Thank you for the great question. Rob something again. Hey, Rob, thanks regarding the phrenic nerve. I was diagnosed with neurogenic and venous TOS pending surgery on the 16th. In addition to the TOS, I'm also having symptoms of paralyzed diaphragm on my dissected side. Sniff test on Friday. Okay, sniff test for everybody here. And Rob, I know you know this. You can watch with a fluoroscope, kind of live action X-ray. You can watch things move in the body. People will use this for like a barium swallow or something, an upper GI. Anyway, you can watch the diaphragms move. You ask the patient to breathe in or to breathe out, and you watch it under this fluoroscopy, and you see if the hemidiaphragms both move and if they both move appropriately. Because sometimes if one is paralyzed and the other one moves, it'll push this one the paradoxical way. Anyway, that's for doctors to look at. So you have a sniff test because they're worried that your diaphragm is paralyzed. Now, if it's paralyzed, the phrenic nerve is affected. And there's a whole range of things that could have caused that. Maybe you have some enlarged lymph nodes. Maybe you had surgery in the area. Maybe you had a scalene block and it wasn't done the best and some of the thing leaked out and got onto the phrenic nerve. That can happen too. I don't want to postulate. I don't want to get too much specific on your case. You have diagnosis of neurogenic and venous TOS, and you can reach out. We can discuss this privately. I don't know who's doing your surgery on the 16th. I hope it's one of our good, knowledgeable expert TOS surgeons. We know plenty of them around the country, definitely more than when I first started doing TOS. And will you definitely get back to us and let us know how you're doing after the surgery? Okay, I'll keep my fingers crossed for you and hope you're in good hands. TOS Inbound, hey there. What do you think about the observation that most TOS patients have dropped shoulders by Dr. Stockton in his book, The Human Spring Approach to Thoracic Outlet Syndrome? So I know Dr. Stockton a little bit. We've had some very brief conversations. I think he spends a lot of time with his patients. He has this approach that's different, in which I'm not expert in. I have a copy of his book, and it's been on my reading list, so I'm only got it part way into it. I want to say to everybody, I appreciate the docs out there, and Dr. Stockton's a chiropractor with a lot of experience, been doing this a long time. And he gets awards in different parts of the world. He travels for that. So I know he's got a lot of experience. He takes an alternative approach, and I think these are really valuable in TOS. As long as docs like me or Dr. Stockton or other docs try new things and they're used common sense, they find things that we didn't expect before. And there's a lot of value in that. You know, if I get some grief from some patients about Dr. Gargazlu, you know, I'll totally recommend Dr. Dean Donahue in Boston. Does the traditional approach, great guy, straightforward with his patients, honest as the day is long, excellent technician, gets good results, but not in everybody because we don't know enough about TOS. Okay, great recommendation for a Dean Donahue. Okay, there's hugely experienced doctors like Rob Thompson in St. Louis. There's docs like Dr. Fareed Gargazlu, who does robotic surgery, radical different approach based on a long story I won't share. There's people like Misty Humphreys in Sacramento, who doesn't decide on her approach till she does imaging because she wants to address different pathologies different ways. Okay, there's a ton of great docs I can mention out there. And Dr. Stockton takes some different approaches, and he has a different paradigm for looking at this. I need to review it to understand it better. It wouldn't be fair of me to judge it ahead of that. But these people are very valuable. He could be right and he could be wrong. He could be partially right. You know what? And those contributions to knowledge of TOS are tremendously valuable. He's probably, just as me, he's probably a different doc today than he was 10 years ago, right? Because he's learning as he does this stuff. So I promise I'll read the book and I'll report back on it. But I think, you know, a doc like that, we should all appreciate for their efforts, right? Any doc who does something different, who's doing the best stuff for their patient, is a valuable contributor to the community. I hope that answers your question, because I didn't read the full book yet. I don't want to comment. No more questions. That comes from TOS Education. All right, so I'm going to remind everybody of a few things. Mash the like button. Help us out here. Go to your social media channels and post one of my blog posts or this video. Throw in a couple of comments, good or bad, whatever you think is good, but let's raise awareness. Let's keep reaching out to TOS people and people who don't know they have TOS. Remember, when you first had pain, you didn't know to search for thoracic outlet syndrome. You'd never heard of it, I'll bet. So nobody knows to search for it. So they're not going to find it unless we make it known. All right. Follow me, TOS MRI, on Twitter and Facebook and Instagram and our YouTube channel, and join up, throw in a few comments, throw me some cute cat or dog pictures. I love to see that as well. I try to follow. Of course, we're very busy, but I love to hear TOS news from people or just fun stuff that you're really living life. We have a talk coming up with Rob Hagan, who's a great guy, really smart, really experienced with TOS. He's one of those guys. We talked about Dr. Stockton. Well, Dr. Hagan does some really different stuff too. Very curious, very instinctive, and very result-minded. And he's going to be a great talk. I look forward to that very much. That's August 30th, as you see on the banner on the bottom. And since we have no more questions, I'm Dr. Scott Worden, the TOS guy. Thank you sincerely, everybody who came here and viewed, and everybody who contributed great questions. I really appreciate it. It helps everybody out. So have a good week and a good weekend. Take care.